Oh my God. Oh my God. Takes a second to go over it. All right, so you have the, remember some of the questions that we have, like what are the conditions that happens with cardiovascular risk? So it's not just the heart. If we have atherosclerosis in your kidneys, that's going to create stenosis, right, on the kidney. But we need to know how does that happen. So you need to identify, like here on the bottom, we have the conditions that happen on each one of the areas, like the narrowing of the arteries, the stenosis, the what is it that is happening? I don't have my glasses. Like plaque or like the intraplaque hemorrhage or the emboli, weakening of the vessel. So if when we're talking about weakening of the vessel, what are we talking about? Like any of this in the aneurysm? Why?
So that's where the vessel will weaken and the blood will just.
Yeah. So the remember the three, and we're going to talk about the three layers of the vessels. So they get weak, and that opening, that weakness does not break the vessel, but enlarges that area, right? There's not enough support, and that's when the aneurysm is there. So one of the risks of the aneurysm is, one, it can rupture. Second, it can create coagulation right in there. And actually, we do that in the heart. We're going to talk about that next semester when we talk about when the blood stays stagnant in an area. So this one is for you to identify. So you have this one in your yeah, right here. So this is what you need to study. So study this first, recognize which areas, what happens on each area, and then you go ahead and do this. Hi. A ver, otro. Marker or whatever it is. There's a packet in there. Sí, sí, jala a ver, sí.
Yeah.
Yeah, all right. But again, this is not for you to feel right now. This is for you to study and then test yourself with this. Hola. It doesn't close or what?
I just
The luck. All right. So does that make sense? This is a workbook. This is not for you to, it's not a PowerPoint to kind of go with the class, right? This is a test study or study guide or however you want to call it. So does that make sense on this one? So you need to identify what happens in every area and what happens if we have cardiovascular risk on the head, stroke, either by stenosis, plaque, or rupture. And if it goes to the legs, it's going to have, well, DVT is a venous return, right? But when we're talking about arterial issues, yeah. So what is happening here? Narrowing of the vessels, or is there a possibility that we have a weakening of the vessel on the legs?
Yes.
Probably, right? But the most common one will not be that. It will be what? Well, arterial, but it will be plaque, right? So what happens on the plaque? We have the cold legs, and we're going to see a lot of that. Some of your clinics will not have every single area that we talk about that we can treat. We're going to focus on the heart. Every time there's a heart, you need to be on the heart cases. There's no heart cases, you can go to the legs. There's no legs, you can go to IR, special procedures, kidneys, and all that kind of stuff. Yeah, but that's the order. I don't want you to stay in IR because you're not going to learn anything about the heart. You can use, the same equipment kind of, but your majority of your exam is going to be about the heart. You're going to have a heavy load in peripheral, so that will be second. And then structural heart. If there's a TAVR, you might not scrub the TAVR, right? That's very risky. So, but you can observe. You can take notes, you can circulate, and slowly get into every area. So this is all that we can do with what we know, yeah? But not every facility is going to have it. And then second page, we do have the anatomy of the vessel. What is the importance of knowing the anatomy of the vessel? Because the disease, where does it start? How does it happen? What happens, right? It's like we just say, oh, plaque. So we just think it's just a collapse of cholesterol in there. In our minds, that's what it is, right? Like, oh, it's just like a little mayo in there, right? But it's not, right? So right? Because patients think that. When you talk to the patients, they don't know. They think it's like, oh, let me just not gonna eat
I'm gonna eat McDonald's anymore.
McDonald's in the next week, right? And then I'll be fine. Things like, does that make sense? So we need to know what happens so we can also educate our patients. You need to identify the areas of your vessels. And then on the bottom, I gave you, you know how I gave you the little, the fold? You can fold the image in there. And then what happens on each one of the layers on this too, right? So what happens on the smooth muscle cells? And what happens on the matrix, right? On the extracellular matrix, where we have all the collagen and all these elements that, remember when we talked about when we had class last week? About that barrier, right? So what is keeping that barrier together? What are the elements? So this is what you need to know on this too. What happens on the layers? Not only what the layers are, but also what happens in there. Because then that's what where the damage occurs. I think I have it here, right? Which is going to be what we talk about in phases. Your smooth cells, how the inflammation starts happening because there's a damage in the extracellular. And inflammation is probably what's going to trigger the disease, right? And this is chronic. And then we also talked about how the plaque develops. So that's your next page. And I gave it to you like that. And so you can actually cut it and then play like memory game, if you will. Yeah. So right now they match, but I would like you to, I don't know if this one, if this one works for you like this and you can learn it like that, fine. You know, some of us learn in a different way, right? Or we all learn different ways. Some of us are very linear, right? We want things like that, 1, 2, 3, 4. That's fine. But then there is another vision in which you need to make connections in colors, letters. I don't know. I like to see acronyms. My way of study is acronyms. So if I learn the first 3 letters, I'm done. That works for me, right? But if it doesn't work for you, then you can trick your mind some other ways. This is what we're looking for in these reviews. I'm not telling you anything that we haven't talked about. It's just like how to get there, right? So if you can separate this and then decide which one goes where, it's gonna start helping you. My daughter, she has like a photographic image memory, and she can see the image. Like if I show her this, she can see this. She might not understand what this is, but she pictures this. Yeah, and that helps a lot because she's a doctor, right? So now she's like, image, everything is image, and that works for her. So she got the right way to use that knowledge, right? She said today, because she was telling me where was I going. She said, and I said, I'm going to a review for my students, and she said, man, I wish we would have had reviews like the ones you're doing for your students. It was hard, right? Because so we need to know the 1, 2, 3 and the order, right? What happens first, right? So the breakage on the first layer of protection is broken, and how does that happen on the fatty strip? We know that this is where the first line of defense is broken, then that's where the damage is slowly, right? And it takes about 10 years, right? About 10 years to any disease to show up. So when somebody comes up and like, oh, you're diabetic. No, you've been diabetic for the last 10 years. You started 10 or more years ago, right? It's not all of a sudden. So same thing happens with the plaque. And then that's what I'm saying. You want to stop for 1 week or 1 month to redo things. It takes a lot of time to, even if there's anything that we can do about it, right? Well, knowing the three. Questions on this? Knowing the progression? Yeah? All right. All right, so we did talk about the cardiovascular risk factors that we can modify and the ones that we cannot modify. So just cut them from the bottom. I gave you, put them together with a line, or you can cut them and put them in there, however works for you, or you can write them or whatever you want to do from the bottom. So all these options are going to be your biomarkers that, remember, biomarkers means probably a lab study. You know, we need to get tissue. We need to get something from you to determine how that is, right? And it's not troponin, right? If we're talking about the inflammation because of this. So I don't care about troponin. I care about if this is, you know, troponin will be later when the disease is like too advanced and then the heart attack happens. And I can only detect when you're having the chest and everything else, right? So right now, this is silent. We do not have pain sensors on your vessels. So you don't know that this is, imagine if we did, maybe that's for a reason.
Yeah, we'd be hurting all the time.
Right, we'd be like, oh, every single day, all the time. Yeah. Dang, I just thought about that. Like, that's the reason. All right, so, for example, smoking, will that be modifiable or non-modifiable? Modifiable. How about hypertension? Now, can we modify the hypertension when it's already chronic?
No. We can control it.
We can control it. So that's where I was going, but they're talking about prevention type of thing more than that we can actually modify. Because, right, when it's actually happening, the high blood pressure, it will be, unless it's like the early stages, but again, it's been a little bit of time, yeah? How about age? No. Even with all the hacks and everything, right? All right, so remember that the smoking is the most modifiable risk factor, according to the books.
So whenever it comes to diseases in the modifiable or non-modifiable, we're going to think chronic. Okay.
Yeah. Now, however, the hypertension, according to our book, it is modifiable. So, yeah, I mean, everything is
Once you're at end stage,
from the
we know
book.
you can't modify diabetes. I'm just saying.
Actually,
At end stage?
well, not end stage, but it's been
You have to be
proved to
like,
reverse it. You know,
well, if your hemoglobin A1C is like
6,
Sixes,
7,
yeah.
8, 11.
even 8, that's
I mean-
high. That's high. It takes a long time.
I mean, and then you have to remember A1C used to be 4.
Yeah.
A1C used to be 4. Now they say normal is 5.5. Why? Because they're adapting it to our diet instead of doing it the other way around. Yes? Does that make sense? So how about to prevent? So that's what I was saying is like chronic or not.
It's like on a basis to basis, but for testing purposes,
For testing purposes will be this, something that we can actually work on. And then, I don't know, if you take medication, control, right? And I don't know. The next page has some of the conditions. I think we're moving on to the next. Does anybody have any questions on any of this? Or comments, clarification, slideshow. All right, so I want you to do here, or I will recommend that you select keywords when you are talking about this, concepts that are a lot alike, right? So what is the difference between stable and variant angina? Select keywords. Don't write the whole paragraph. There's no need for that. Select keywords that identify one or the other. That will be like, it's just basic stuff. Words that you can recognize. All right, so anybody has, okay. Let's go to the next page. And we have the, so this one, I want you to do it when you have already studied. So study the concepts and then come back and just select. I put S for supply or D for demand on the myocardial oxygen, right? So for example, if we said contractility, would that be supply or demand? Right? So then you go ahead and do D, but use it after you study to test yourselves, right? And then I did the same thing for the causes of myocardial ischemia and the clinical presentations of stable angina. And I gave you the initials, fixed vessel narrowing, and endothelial cells dysfunction or other. So then you're gonna select for example, in fixed vessel narrowing, it says fixed vessel, so that means that's how it is, right? So anatomy will be one that there's nothing we can do. Oh, I thought it was somebody else. Yes. So in here, you're going to do anatomy will be a fixed situation. Because if I have the vessel like that, there's, I'm 5'3" and there's no other way, right? Unless I get the surgery and then, I don't know. I don't think I'd like to do that.
It's very painful.
It's very painful, extremely painful. Yeah. And then for what? And then money and I don't know. And then I think it stays on your head the whole time. So I don't think you're even going to be over it. I don't know. All right. So, and then when it comes to endothelial cell dysfunction, this is when we start talking about the damage that we're starting to have, like when the vessels cannot vasoconstrict, that will be stenotic, right? Or they cannot dilate, or right, they lose their function. That has nothing to do with anatomy, but then the cell dysfunction starts getting diminished or lost because of something happened, right? So cell dysfunction. So when you read the word dysfunction, it's like, okay, what are some of the things related to a dysfunction? Like fluid mechanics will not be dysfunction, right? That will be fixed. Other causes, I think that's open to discussion because there's so many things that could happen on other, right? But then just for that, I was talking, we are having a sterile processing exam tomorrow as well. After yours, then it's sterile processing. So a question came out because we played a Kahoot, right? Because it's an online class, so we have to kind of make it a little fun. So it was a question and nobody got it right. They all knew the answer, but nobody got it right. So the way to choose that answer was knowing what is not. So we went over that. So is it this? No. Is it this? No. Is it this? No. So how about this one? So by default, process of elimination, this is the right answer. And then when they went through that process and then they reread the answer, oh, that makes sense. And that's going to be for your RCIS. It's extremely tricky. Those are the words that I can use. Somebody took a certification exam yesterday, and he was saying it's not that I didn't know the material. I know all my material. Is the way they ask the questions. He said the first question, and it happened to me too. When I first opened my RCIS, the first question, I didn't understand the question. So I was like, oh, I'm lost. right? Like, I'm fried because if I don't understand the first question, like, it was like Chinese to me. I couldn't recognize the words. Like, it was just like, so he said, the first 20 questions, I didn't know what it was about. Like, literally, I didn't know. And then I said, okay, strategy. I'm going to answer the ones that I know. And then, and he said, halfway into the ones I knew, like, oh, let me go back to the ones. Once he was more calm, right? Like, relax, you got to flow, like, you're not that bad, right? So the brain started to come down and being able to analyze the questions. So I would recommend that. Look for words except, always, never. Yeah, all those words are kind of like tricky.
All that apply.
All that apply, that one is tough, and you're going to have some of those. So on this one, everything that is not fixed or dysfunction will be other. Yeah, I mean, that's one way to learn, right? Like, by knowing what is not. Are you gonna put that on YouTube? You're gonna call me on that. That's one way to know. That's one way to learn what is not, right? All right, and then we have the clinical presentations of stable and genetic. Study this, talk about this, read to yourself, talk to somebody else. I had a student that, remember, she had a dog. She had nobody to talk to. She was teaching the dog. So the dog is expert in CATLA because the dog will, I mean, she will interpret that just to teach, right? So get all this, and then you come back and answer and see how many you got right. And based on that, like, okay, I need to work more on this or not. Risk factors, of course, we've been talking about that, right?
In stable angina, the frequency is not frequent. It's very controlled as you take your meds and all of that.
Yeah, but this is when you're not taking medication. You're thinking doctor. Yeah. And that, does that make sense? We're talking about, this is the presentations when our patients come.
Oh,
Right? Does that make sense?
Yeah.
That's what I'm telling you. You're going to the doctor level, trying to be on the other side. Yeah. This one, you can go through it just for general knowledge, but we've talked about this. You know, chest pain could be anything. Could be gas. My daughter one day was like, oh, I'm dying, my kidney, she was dying. She wanted me to take her to the ER, but I was like, no. You know, knowing what you know, and then I was like, no, you're fine. Oh, you don't love me, blah, blah, blah. Drama, because when you're in true pain, really, truly happening, you don't have words for that, right? Now, like, no, you're fine. I said, go to the bathroom. And she's like, no, take a gas X. You're joking, blah, 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 I'm really dying. And yeah, it was gas. You know, at the end, but she was already on the ER. She was already having surgery, blah, 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 right? And that's a problem when you know too much,
Yeah.
right? You know, she was already in school for a doctor. So like, your mind is going too much, right? Yeah. And I was like, nah. Oh, you don't care, right? Typical. So there's all this could possibly cause chest pain. So imagine if you have biliary colic. So, you know, your gallbladder might be not really up to par, right? Reflux. And of course, if you have pericarditis, right, or myocardial ischemia, then obviously, but there is very specific symptoms. I had a friend, and he was doing, I think they were moving or something, and then all of a sudden he felt a pain that has never felt before. Weird. And then he started to sweat cold, and he said, I hope I'm not having a heart attack. Cabbage. He ended up having a cabbage.
He explained this to me. I had the chest pain. I had the radiation. I had the numbness and tingling. Blood pressure 180s over 90.
But you got nervous.
I was diaphragmatic.
Uh-oh.
I
No,
had
what's-
like shortness of breath up, and
Yeah.
and it was pain that I had never had before.
Yeah.
I was
Oh, what was it?
Labs were fine. CT was fine. Or all organs are fine.
So nothing?
There was nothing there. I
Okay,
think a
sir.
diaphragmatic spasm
It could be.
because the chest pain was there for like 4 days.
Oh, wow. They have you in observation
I
or no?
was here in school. No,
Oh.
I got a midterm the next day. I was like, I can't stay. They wanted to do an
What, you were here
Yes,
this semester?
yes.
When did this
During
happen?
midterms was my lowest grade. The night before I was in the ER with chest pain. I was here with chest pain.
Oh, wow. And you're like, yeah, I know.
Yeah.
Oh, wow. Dang. You should have said, can I go do an EKG?
I had an EKG short.
Well, with us. Like here, like, can I do an EKG? Because you were here on
I
Tuesday.
have the EKGs. I have the EKGs. So
Caffeine.
that's why I did want an echo. Because I did want an echo. I'm
We have echoes here. We have echo machines, students. We have EKGs. We have,
So the
I've
EKG,
had-
you tell me, was
the
a
nurse
short
have-
interval, so that could
Oh.
be an indication of pericarditis, but my symptoms weren't there because there's relief when you.
oh,
there was
with
no
movement. Oh, it was no relief? Oh my gosh. Well, nerve entrapment too. All right. Well,
Oh, and my heart rate was in the 40s
oh, no way.
with a blood pressure that high. Explain that to me.
Damn.
When
Well,
was that with Fiesta?
it was, I don't know. I mean, the heart was responding to something, right? Like, obviously, the correct way. Well, I'm glad you went. I'm glad you went to the ER. I didn't go through this. We will never do examination. This is just for basic knowledge. Sometimes it's good that we know a little bit, but we are never going to diagnose anybody. Never. What we're going to do, we're going to be on the monitoring system, and we're going to detect changes on the EKG, changes on the blood pressure, changes on the temperature. This we need to know, but we're never going to diagnose anybody. And when somebody comes to you thinking you're the doctor, direct them to the nurse, or even with a doctor question, direct them to the nurse, direct them to the doctor. Oh, ma'am, sir, I'm a tech, so let me get you a nurse for those questions, right? Or somebody in the family. Everybody calls me thinking like I know everything, and I'm like, no, I'm not a doctor. I just know that, blah, blah, blah. May or may not. And sometimes you don't want to tell them because look at my daughter. Like, no, thank you. Call her. Now they can call her, right? So, yes.
What are brutes?
The brutes are you feel like bubbles on your pulse.
So is that similar to like pulmonary rattles? Or because that's like bubbling?
So the sounds when you know how they do the auscultation, they listen to your heart and then they listen to your lungs. So the sounds will also give. Oh my gosh, what's the word? They have a normal sounds. Or for example, imagine that you are having, I don't know, even if you have a, nah, let's not get into that. But does that make sense? Those are diagnostics that, because we know what normal is, then we know what is not normal, right? Does that make sense? But again, the diagnostic, this section is just for you to kind of have an idea of, but we're never going to diagnose anybody. Okay, and please don't do it for your family either. Don't. All right. This is what you're talking about? Yeah. So imagine when you have the pulmonary congestion, you're not going to be able to. You feel it. You can't breathe properly. So imagine how it's feeling inside. You know, half of the workers are like knocked down. Right, so that's what the sounds are going to be. That's what their responses are going to be. This one, the mitral regurgitation, we're going to talk about that next semester when we talk about hemodynamics and what happens when the valves are not working properly. And so that's when we're going to understand this a little bit more. But that's why I don't have anything on that. All right, diagnostic studies, we've already talked about that. I mean, you should know them by now. You did assignments about what are the diagnostics tool. And for cardiology, it's going to be pretty much all the same, echo, EKG, ultrasound, right? Basically, they're going to be the same. And of course, biomarkers for us, stress test. Sometimes we're going to have some patients that are going to come to the lab, or maybe we're going to do it on holding, that they do get like a temporary monitor. And it's just like a AA battery flat that gets inserted by the heart and is going to, people that are having episodes like they can loop recorder. So we may or may not recognize what is triggering, or so we get a loop. Some people get a holster, and some people get the loop. So
Isn't the loop super expensive?
I don't know.
Like 70 grand or something like
No,
that? Yeah, Wesley got one done.
$70,000.
Well, he didn't pay the 70, the insurance did, but I thought it was the procedure itself is expensive.
The procedure is 5 minutes.
Yeah.
And it's not even in the OR. It's in the holding. It's a plunger. Literally, it's the two things that you put together. You put together, like you load it and then inject, and that's it. Yeah, I guess in the skin. I don't know.
That's what he told me.
Well, I've never been on the admin side, but I don't know. Now, I've never seen loop recorders on the civilian side. I've only seen the recorders on the military side, and they were right and left, and they're free, right? I don't know if that has anything to do with it now that you're talking about it, because I've never seen recorders on the outside. Maybe that's one of the reasons. They will do a holster. It's cheaper for the insurance. Will pay for a holster instead of the surgery, right?
It's not as accurate because there's a lot of artifacts in you.
Yeah. And then if you take it, if you don't take it, if you, right, things like that. There's a compliance on that. Now, I do have treatments on your paper, match the following concepts. I should have put pages on it, but treatments to prevent or an episode of acute episode of angina or angina.
It's a damn liar. It says 15,000.
15,000, yeah. It sounds more like it. And then with all the discounts. So is it angina or angina? No, what do you say? Angina? Angina? Angina?
They say
Angina?
angina, but you're the one you never
Angina.
speak Spanish.
Well, it's not Spanish, it's Latin. Angina is actually the right word in Latin.
Yeah, it's Latin, so yeah.
But I hear them say angina.
Angina, because it's in English. Yeah, so if somebody corrects you, tell them it's,
Well.
well, let me tell you, Latin in medical terminology, right, is like, all right, so, no, that never do that, right? Go with it, just go with it. They already come with a chest pain, so like, no. All right, so to prevent recurrent ischemic episode and to prevent acute cardiac events. Do I have it here? Oh yeah, here. So these are I only did the 3 on the top because obviously revascularization, and we already talked about that, right? The obviously it's an angiogram, angioplasty, PCI, these things, right? That will be that. And then the difference, we're going to talk about that here in a minute. So when we do the acute of angina, the first thing that we're going to do, we're going to treat the patients with antiplatelet, aspirin, baby aspirin, right? They're going to be prescribed that, ACE medication, maybe statins, platelet antagonist. Do we know the word antagonist? What is antagonist?
It's basically the opposite.
Opposite of what?
An agonist, which is basically agonist won't cause the reaction. Antagonist is preventing that. Yeah.
Preventing. What did you say, Loretta? Preventing, right? So we are going to prevent the form of plaque because we already have the damage, the plaque forming, right, in the endothelial cells, right? Does that make sense? So that will be the first set of treatment. When people start coming with chest pain, getting tired, not everybody gets into the cath lab right away. Cath lab is like the last thing, especially in the civilian side, because insurance, they're going to try to start for like, oh, go with your primary, then go to get a referral for your cardiology. And then cardiology is like, oh, go do labs and then go. So it's a lot of back and forth before they get to us, right? So imagine having pains. I was going to say, I saw it last week in clinic, and I've seen this all the time. The doctors don't educate the patients of what's going to happen on the cases. When we inject contrast, it feels like hot chili pepper inside of your chest. And doctors don't tell the patients that that's the feeling, what to expect. If the patient knows what to expect, they'll be fine. They're like, oh, this is it. But imagine you're already going in for a heart condition, and then all of a sudden you feel this overwhelming heat on your chest. What do you think?
I'm dying.
Yeah, I'm dying, right? The heart rate goes up just because they experience that. And then the doctor says, oh, I forgot. I should have told you that, right? I wanted to like,
So like if we're prepping the patient, are we?
yes.
Can we tell them
Yes.
during that?
Yes. Yes. So you're gonna feel this. We're gonna do this. We're gonna na. When we inject the contrast, you might feel a little chest, something. If depending on the level of openness of your patient. So I've had patients that say, "Don't tell me anything." Okay. Good luck. And some patients they want to know, right, what to expect. Is it gonna be? Well, that's why I'm saying. Make sure you tell them it's cold when you clean the groin. They're like, huh. Right? Like, what's going on? So that doctor, it was kind of young, but still, if it's not on the doctor, you do your part. Talk to the patient. You're going to feel this. It's going to happen this. I want you to stay this. Don't move the legs, because the doctors might not indicate the patients. You're going to have to be flat for the entire situation. Can you stay flat? Majority of our patients, because of age, they cannot stay flat on that heart table. So I will put a towel under the knees just to release the pain a little bit. Just a little bend, that will release greatly that pain. Are they cold? Are they hot? Big males, they're hot. So they're in heaven in the cath lab. It's cold and fresh and nice. And then you go ahead and put your blanket, the warm blanket, and then the drape is like, oh, it gets too hot. And then it reflects on the vitals too, right? So you have to, and actually your RCIS does have a lot of nursing questions like those. Believe it or not. When I was taking it, I was like, man, this is a nursing test. And same for surgical tech. A lot of the questions were nursing questions. So that's why you have to take notes on the nurse. The nurse should feel the part of your clinical evaluation on patient care. Right? So you're going to talk about consents. You're going to talk about prepping the patient. Positioning, yada, yada. All that is pre-op, which will be patient care. Yeah. And then post-op is also patient care. So pre, intra, and post compose peri-operative. So pre-op is before operation, intra-operation, and post-operation. So all together is peri-operative, right? So since they come. Speaking of that, when do you think pre-op starts? If you know, because you are in the medical, keep it down. So I want you to think, when does pre-op start? Pre-operation. No. When the patient signs in to be admitted. When they get the bracelet, that's pre-op. That's when pre-op starts. When does pre-op end? So we're going to pre-op, intra-op, and post-op. So when does intra-op pre-ends and intra starts?
When they're in the cath lab with roll.
That will be intra-op? Lidocaine. At lidocaine. So timeout will be pre-op. Yeah. So does that make sense? Because that's when you're actually doing something to the patient, and that for us starts on lidocaine, right? Or if they do the ANSEF or whatever they do, medication. Yeah, that's when intra-op. So when does intra-op end?
No.
What goes after the sheet? Right after the sheet. What do you do, huh? But what do you do after compression? Huh? Could be closure device, but right after? Dressing. Dressing. At dressing. As soon as you apply dressing, intra-op ends. So that's post-op starts. And then post-op ends at discharge when the patient leaves. So all that occurs. Yeah. Right. And we were just talking about antagonists, right? Platelet antagonists. We're going to have a few things on your RCIS about antagonists, especially medication and things like that, but that will be next semester in your drugs class. To prevent ischemic episodes, when somebody's already having, like, getting tired, oh my gosh, getting tired walking the stairs or just, steps, or, oh my, I get a chest pain after my run. Well, the first thing will be stopping the run, right? Like things that will cause that. We're also, if it's something that is already seen by the doctor, they're gonna prescribe nitro or give nitro, right? Which is a vasodilator, and nitro or something else. And then to prevent acute cardiac events, this is the treatment taken home, right? The blockers, beta, calcium.
Ranolazine is from Giant.
That one just works on the calcium on the muscles, right? So to prevent that. So, and then the nitrates, also nitro, to dilate a little bit.
Ranolazine is also for pain.
It's muscular. Yeah. Yeah. So it relieves the muscular contraction and therefore pain, because we need for the muscle to actually contract, we need the calcium. Remember the action potential?
Yes.
How does the action potential occurs?
Starts off with what's
Sodium, calcium. So this movement of electrolytes within the cell are going to cause the contraction, right? So removing one of the elements will subside that. Yeah. All right. Well, we went over this briefly. Go over the basic stuff, right? Like heart rate. Like all of this are going to want to, and actually this one too. So the channel blockers are going to reduce the heart rate. How would it alleviate the heart rate when we diminish the heart rate?
Calcium is needed for action potentials. If we limit the calcium, we limit.
It's the same thing we were talking about, right? So the calcium will minimize the contractions. So a beat will be a contraction, right? Which ultimately leads to heart rate, right? So how many contractions per minute is the heart rate? And then here we did talk about, what else did we talk about?
The coronary perfusion.
The coronary perfusion, that will be for the calcium channel blockers, right? And then the myocardial oxygen demand will diminish. So that means that it will stop the heart from giving too much. It's gonna keep it like low key, right? Really, that's what we wanted to do, like stop that reaction, because as soon as that happens, it might get into the episode again, right? And again, this is prevention. This is not repairing anything. This does not repair anything. This is just a treatment. And this is maybe people that don't want to have a heart cath. They don't want to have surgery. Does that make sense? So not everybody is like, oh yeah, fix me. Not everybody's like that. There's a lot of people that, no, I don't want that.
Say that the ACE inhibitors are like the what do you call that medication? Xanax of the vessels.
Oh yeah.
They relax the vessels.
You're gonna be. We relax the vessels, and then the blood is thinner. So it's a mess, right? Like the end of the day, right? Like, so that's why prevention is like so important. But
You also want to know about the GP, like 2B.
No. No, we're just talking about the platelet antagonist when we're talking about that, because we have. So what will be a platelet or platelet antagonist that we use in the cath lab?
Aspirin.
In the cath lab.
Oh, cat blood.
Yeah, and then
Yeah, by rule limit.
Huh?
Vivaluronate.
I thought it was nitroglycerin. That one is usually if they are allergic to the nitroglycerin.
Nitro is for
Nitro.
vasodilation.
Right, correct.
Yeah.
But there is the one, it's very difficult to.
So we have antiplatelets and anticoagulants, for example,
But
right?
the one I know what you're talking about, but usually they use that one if there's an allergy to nitro, if I'm not.
I don't know. Which one is it?
I don't know how to pronounce
Yeah,
it.
Vivaluronate or
Oh.
I would need to look.
Take
it
note
up.
on that. Take note on that. All right. So remember, I told you every patient that comes to the cath lab, they're going to give them the aspirin, and then that's the antiplatelet, and then we need to give an anticoagulant, which will be what in the cath lab?
nitro.
Heparin. No, nitro.
Oh, yeah.
Nitro dilates, right?
Heparin's going to be in the saline, but they do tell patients that they need to stop.
We
their
also-
course and-
Well, yes. So this is the thing. Patients are taking antiplatelets and anticoagulant medication when they are in treatment, right? Beforehand, before anything else. They need to stop their medication about 7 days prior coming to the lab because then that blood will be a mess.
Super,
Yeah. Now, when the patients come in, we have heparinized saline. And we also give heparin in addition to that, depending on how long we're working on the patients, right? But that is control, right? So we're going to give 1, 2, 3, 5, 10,000 units of heparin, however long the case. The longer the case, the more heparin we're going to be doing, or the more devices, right? The diameter of the devices. And then at the end of the day, you already talked about ACTs, right? Taking the ACT of the patient, because if the blood is like too thin, it does not have any platelets, it does not have any coagulants, try holding that manually.
An hour and a half.
3 days, right? Like 3 days, because that blood, I mean, eventually it will be back to normal, because the body's going to try to go back to homeostasis, but it's going to take forever. So what is the number that you got for ACT? 180? 200. Let's stay in 200.
I said 200, but somebody else. said-
Let's stay in 200.
Yeah, which somebody said 180.
Who?
Yeah, Ben said.
Yeah.
Okay, let me tell you, Ben has not been in the lab for a long time. For a long time. So
So we're gonna stick to 200.
200, my doctors wear 220.
You also mentioned.
Let's do 200. Let's say, who?
No.
No.
220 is what you
220.
mentioned first.
220, because that was the practice that I lived in. But then going to clinical side, I hear 200, not less than 200. So you're going to go take your ACT, right? And you're going to know you're going to get an ACT because you're listening to, give 2 of heparin, 2,000 units. And then another 15 minutes. How long has been? 30 minutes. Okay, can you give another blah, blah, blah? Another 5, another 6. So you more or less make your numbers. And if it's over 5, you're going to need to stop that, right? And sometimes we give 14,000 of heparin, especially on EP. The cases are long. 5, 6, 7 hours. So we're going to need to give protamine because it's the antagonist to the heparin, right? So that would be a question on your RCS, yes or yes, like 2 or 3 times. Yeah? But that's in the cath lab.
So what mentioned anticoagulants, UFH, LMWH, Bivalirudin?
Oh, Bivalirudin? Yes.
Yeah, that's what it-
There
Yes,
you go,
yeah,
that's what it
yeah.
is.
So those are administered only once, but when does that occur?
When do we, and it's not for every case. It's not for every case. Those are some of the options. It's like if we give all this treatment for everybody, like flat, no. We need to take into consideration other conditions
When would they be given that, like upon like surgery?
and during surgery,
Okay,
during. Or procedure, right? Because we don't do surgeries. It will be procedure. Yeah. The most surgery we do is going to be a pacemaker. And we're going to talk about next semester. All right, so we already talked about this, right? Yes, Liz.
Just like authority agreement, said 200?
200. 200. And then when you go to clinicals, let me know what the doctors are saying. There's a lot of new doctors, like young doctors, that are going crazy. They're on the loose, like doing things that should not be doing.
How do you mean?
What do you mean by that?
Like give a lot of heparin and not giving enough protamine, for example, or Tymo. Like, no, that'll be fine. You know, things like that. They're making these decisions, and you're gonna go into the cath lab looking at this. The new doctors, you're gonna see the difference between well, we almost have no OJs and then the more traditional doctors, and then the new doctors. The kind of ninjas are coming in. Yeah. Yeah, so we were talking to Dr. Chilton. Remember Dr. Chilton? He is our medical advisor for the program. He's leading the program in the VA and a university. He was also saying that he's very worried about the fellows coming through because they do not have the experience, they do not have the knowledge.
That's scary.
That's very scary. And so he's asking, and this this is for us, you know how our minimum is 77? He's asking for the minimum to be 80. He's a medical director, and he's like, I don't want to do that because he's already seen the decline in the doctors. And he said, and then the decline. He's like, no, I don't want that. So probably the next board meeting, he's going to talk about that. And here at the college, across the board is 77 for healthcare. But he said, like, who came with this? Like, he's probably not a doctor. Like, okay. So, yeah, that makes sense. So
The standard should be the highest.
that's what he says. He said that we're having to lower our standards because this new cohort or new generation is like, no, we can do this. And it kind of makes sense, right? We feel that we can do more things with the support that we have, but certain things are not going to change, right? Like it has to be how it has to be. But let's explore those.
But see, even if, let's just say the situation were to happen that the technician is very good, experienced,
Yeah.
but there's a new physician that comes in, at the end of the day, you follow the physician's order and direction.
But you can also push. But there's a lot of instances in which the techs catch some stuff.
And we can say something?
Yeah, we can say. Yeah, I cut twice wrong side, for example.
What?
Wrong side.
Didn't you say amputation or something?
Well, no, that imagine if it's an amputation. It was in the cath lab. In the OR, let's not talk about the OR. OR is because there's many more options in the cath lab if you think about it. For us, it's like right or left, right? So I cut it twice, and I was like, whoa. I thought it was, and you can speak freely. You should have the freedom to speak up on behalf of the patient. Now, if it's every single case, if you're nagging, if you just want to be a smart ass, like, no, we can't do that. There's a limit. So if you notice something, talk to the nurse. If you don't know the doctor is not willing to listen to you, because some doctors are like, you're just a tech. Like, no, I'm your tech, right? So, but talk to the nurse. If you make a team, the nurse is charging and she's responsible. So somebody will listen to you, especially when you catch items, you're going to start gaining respect. But again, use that power wisely. All right, so we already talked about this, the two mechanical revascularization. Mechanical means we're doing something too. It's not medication, it's not treatment, it's actually a procedure that will be PCI or surgery, right? And then I gave you the, you already know how this happens, I hope, right? This one we went briefly over the CABG and we can probably do, if you want, we can, next semester we can go over what happens in a CABG, like in an actual surgery. How do we prep the patient and things like that? I mean, it's not competent to us, but you might want to know, right? Because we never go to the OR unless the OR comes to us. So here is just the comparison between a PCI and a CABG, when and how benefits a patient, and if it does benefit the patient. Like for example, somebody who only has one lesion, PCI will be the best shot. There's no way to have a patient through a CABG for one lesion. No way. Even two lesions, I don't know. And now CABGs, I've seen triple, quadruple, and quintuple. So five bypasses, depending. I haven't seen more.
I've seen 6.
You've seen 6? Oh my gosh, new heart. Dang. And you're gonna start recognizing how the heart looks when we do that, the shots, and the vessels look terrible. You're gonna be like, oh, you already know. You're gonna start getting that perception. So, like we said before, PCI is less invasive, but it's not as efficient in somebody who needs a multi-vessel. However, some multi-vessel need or lesion patients, I want to say patients, cannot do CABG for other conditions. Then we're gonna try do very controlled PCIs and a series of procedures, 1 or 2 at a time. Does that make sense? And it's protected, and we're gonna have rotablator, we're gonna have Impella, we're gonna have all the gadgets available to do a repair in which patient cannot go to the OR. So we have a meeting. We have a meeting with the cath lab with the CT cardiothoracic surgeon. We meet briefly. We take a shot. Remember, we said, excuse me, we said we take a shot when we see this angiogram and the vessels are like really not looking good, multi-vessel disease, and we're like, okay, it's gonna go to the OR. And then the doctor is going to ask for a Lima catheter, which is an LM, and then take a sample how the Lima is looking, just to see if we can use that graft first. So when they ask for an LM, or you're going to be like, oh, they're taking a sample. It's for nothing else but to give the doctor, the actual surgeon, a heads up. It's looking good, right? So in that case, for a patient, and it's more permanent because the vessel that we are implanting, in this case, the vein, is not deceased, right? So that way we can guarantee. And I've seen cabbages or grafts that are actually plagued and damaged within time, but this patient typically not compliant, not taking medication, right? Yeah, and then there's this mindset from the patients that we are fixing them. They can still do their lifestyle, they don't change anything, and then we can give another PCI or medication or another surgery, and you're gonna have a lot of the patients that are like that, and then we have the patients that are really, truly caring about themselves. And and I think that's pretty much it. On this one, you can match the concepts, what's in for what, and I think there's one more. Oh, we have, I added a little bit of the diseases of the pericardium. I think it's only 2.
That's 4.
No, I like 2 pages,
Oh.
right?
Restrictive pericarditis is not going to be a part of that because it's muscular.
It's stiffness. It's not really muscular, but it's like, it's a balloon that is like, that has nothing to do with fluid or anything. It's just the pericardium is unable to, yeah.
So this one is the removal though. So what would be the treatment for restrictive?
Constrictive and restrictive.
Right, no, so constrictive, I know it would be a removal of the pericardium, but what would be the treatment for restrictive?
It's going to lead into constrictive, so time, I guess.
Eventually.
Yeah. So some of the things that you need to know about the pericardium, and this is going to be on your RCIS, the contents of fluid in the pericardium sac, 10 to 50, right? So it's either 1 10 cc syringes or 5 cc syringes, max, just to give lubrication, right? So this is the balloon that is around the heart, right? The fluid inside. So it's the heart, the fluid, and then the balloon, right? So this fluid allows the heart to, that friction, the beating friction, right, to be soft, because otherwise it'll be rubbing against other organs. It will also, the pericardium also helps preventing infections. So this is going to stop, because we have the lungs next door, and the lungs are direct, it's a mucous membrane, right? Connection to the outside, so believe. What else? Oh, it's a low pressure, -5 to 5 millimeters of mercury. So this is very, very no pressure on that. So those are the characteristics that you need to know about a normal pericardium, a healthy pericardium. And then on this, just describe, again, select keywords for the diseases. Don't go like blah, 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 blah. Just very specific so you can remember, because otherwise if it's long, you're going to lose it. You won't remember. And how do we treat it, or if there's any notes on that? Yes.
You also want to know about like predominant pericarditis and like TB carditis.
TB?
Yeah.
No, just this fourth.
This is 4. Alright.
Just this fourth. Yes. We're going to see pericardial diseases in the cath lab. Yes.
A few of us were in study session and we were, what is, we were confused about what HCO is. It was shifted, or is it hypertrophic obstructive HOCM? Yeah.
Yeah. It's visual.
That's when the symptoms like thick.
But I was just asking because it was in one of the previous cases we told.
And it was on the previous chapter, no?
It was week 6.
Are you referring just to the fact that it was just the acronym and we were verifying
Yeah, I
that?
was just very good.
And so what is the question again? Because
What it's
looks like
she said. It,
okay.
yeah.
So yeah, you got it.
Yeah.
All right. So I need you to know what is the difference between arteriosclerosis and atherosclerosis. You need to know the difference between the two. What else do we have from the first exams? Let me see.
The timeline. I think those are the timelines.
The timeline?
Yeah.
Let's see. Oh, you're gonna. Is it gonna be?
Oh, you need to ask questions.
Mine as well.
You want us to know the timeline by heart or is?
No. But for example, congenital defects, you're going to have some congenital defects on your exam.
Oh, fetal circulation.
Fetal circulation, yes. Actually, the first weeks of the embryo development, yes. Let's see, what was on the first one? First week, we don't have anything about the heart blood flow. You should know that one. Yeah, I feel we don't have to do that.
So for the baby, you want like the first 21 days until.
The first 40 or 38, what is it? Days?
So the try.
38, yeah. That is for, some of those questions. Congenital cardiac defects, basic ASD, VSD, the main congenital diseases, tetralogy, what is it called? Well, of course, PFO, on the ASDs, location, which one is the most common? Yeah,
I need to know if it's like a right to left side or left to right side.
maybe.
When it comes to the shunts, what indicates if it's ASD or VSD? Like I know if it's a left or right, but how do you know if it's
The
a
pressure in the chambers.
So it's going to be does this one work, or I've never used this? Maybe not.
Is it a whiteboard?
I think
No,
it's a
that's
smart
a smartboard.
I think it's, yeah, I don't think I can use in that.
Pick up the screen.
Oh yeah, pick up the screen.
But then I'm going to have to bring it back.
You want me to hold it up?
Nah. So what you're going to do, Lucia, you're going to, is that a erase?
I am
Right, erase.
It's sure.
Oh, look at that. Thank you. You're going to have to realize, how we've been doing the case studies, right? So you need to, just by the case studies, you should be able to see with the information that we get from the patient, because when we give saturations and everything, we've already done a right heart. In the right heart, we get the saturation, hemoglobin, blah, 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 right? So your patient information will be your age, because remember, some of the conditions are male or female. Age, because age has a lot to do with it. And then we're going to have heart rate. Within the heart rate, and then blood pressure. The blood pressure is going to give you a lot of information, right? And then if we do a right heart study, we're going to get pressure and hemoglobin from every chamber. Pressure of hemoglobin of every chamber will tell you where the defect is, right? So for that, you need to know the normal pressure from every chamber. Pressure and saturation, yeah. And I want to say oxygen saturation, because if it's somebody here with respiratory knowledge, they're going to be kind of like, that's not it. But for example, right atrium is going to be 0.5 and the saturation is about 75. Now, if it's 73, that's fine. If it's 76, it's fine. So we have to,
86, we know that they're made.
but now if it's 86, that's not normal, right? In the atria, on the right atrium.
Because for one of the questions, it was 85% for the right atrium. and
Is that normal?
So I was like, where is it coming from?
Okay, well, but let me tell you, can the blood come back from the ventricle to the atrium? Not to move the saturation to 85, no. No, it's just gonna be a little, but it's a little,
The atrium.
but that's what I'm saying. So that's where your knowledge starts pumping up, right? So if you have an 85 saturation on the right atrium, there's no way the defect is on the ventricle. No way. That blood does not come back to mix 75. So it will have to be 95, from the ventricle on the bottom, which is already mixed from, there's no way. There's no mechanical, physical way.
Oh, because of blood flow.
Yeah, exactly. So now you put the blood flow, like if it goes this way, but can it go this way? We're gonna talk about regurgitation, but it's minimal.
And when would it be BSD?
So if your atria is normal, so you get 75, right? We're talking about, does that make sense? You go to the ventricle and you're like, oh, this one on the top is fine. And then the one on the bottom is like, no, so good. That's what you identify, atria and ventricle.
I think, yeah.
Does that make sense? Okay, so I didn't have to do this. All right. Oh, I get it. Yeah. Mm-hmm. All right.
Right.
Well, actually, let me see.
You gotta get going a little bit.
Huh?
You gotta get going a little bit.
You have to go? Yes.
So bossy you are. I'm just kidding.
No, we do.
So nervous right now.
Yes, be you.
They just want to know how you are. So don't post anything. Just,
Scared.
I mean, the expectation is that they want to know a human, right? Like,
Yes. Be you.
Be you.
Your true personality. Is that
All right.
the one they're gonna see?
Yeah, I can see, right?
all right. Huh? Yeah, no, we know. And Liz, I'm gonna have to change yours.
Okay, actually.
Yeah. All right. So we already went over this last chapters, right? You need to know.
I need camaraderie. I know we're all
The what?
I need camaraderie, like, because she was gonna be alone, right? Just
Most labs are going to be one person. A few are two, maybe three, but most people are by themselves. Yeah, sorry, Charles. When we talk about pericarditis, you need to know the tamponade, the acute, blah blah blah, all those descriptions. The procedures, the repair procedures for congenital diseases. You know how we did the basic, the matching.
Norwood, Glen, Montana,
Yeah.
Fresh.
Rushkin.
do you know we tried from it flashcards and I went to sound like wrong. It's okay then. It's all
Okay, can you distinguish the differences between
No,
a Norwood, Norwood Sano?
That's the same.
don't go too much. Yeah,
It's the
it's-
same. Norwood
it's a
Center was
variation.
just two physicians. It's-
Yeah.
It was,
Okay,
but.
okay.
there's their own version.
We were arguing yesterday about.
Don't argue. Don't
I think
argue.
For the left heart, right,
Yeah.
the Norwood is the first procedure that they do.
I
They
said,
say they're interchangeable between the blah, 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 that one.
Blah,
Blah,
Cossack.
Tossing and the Norwood. But I know for left, according to the research that I've done, Norwood is first for the left. So for right,
Okay. Don't get too much on what goes first and what goes second, because it depends on the doctor. What do they want to do?
so for.
And then we have a ninjas.
I told Leslie,
Doctors, believe me, in the OR, it gets worse. Right? Hector knows. Or we do things that maybe we should not be doing.
See, my understanding of the Blaylock plasma gun was that was used for blue babies, cyanide.
For the
Right, but we were just talking about left and right,
Yes, we would do the Blaylock.
plastic.
Yeah, yes, you would do the Blaylock first. Because that's
See,
what happened.
I read that it was the Norwood first. Whatever, they're interchangeable, whatever the doctor wants.
so
Question.
you were right.
I don't know you, snap.
I think you owe me double.
Whatever.
And me.
So you need to know the ASDs, right? ASDs, fossa valis, PFO. Yes.
STEMIs are gonna be asking about that?
Yes.
STEMIs?
Yes. How do you recognize either or?
If it's like transoral, are you gonna do that too?
All three.
Well, it's a characteristic, right?
Are there gonna be case study questions? No.
Yeah. That's low.
But let me see, it's
Yeah.
Nevada's case studies. It's not Ochoa's case studies, right? It's not that crazy.
Also, can you
No,
please explain the AKG one? On
For the
case study-
STEMI?
On the case study one?
For the STEMI?
Yeah, because it was showing that it was like STEMI, right? One of them, because there were the tombstones. But also, it says in the book that acute pericarditis also has
Yes,
those tombstones. So
yes.
how do we,
It's like she wasn't there. You know, because in pericarditis also you have an ST elevation.
But you confirm a study.
You can, how do you confirm?
with the 0.1?
With troponin?
With troponin or-
Da, da, da.
Pericarditis. That's the thing. So in that question, it didn't mention that.
It doesn't have to, because it gave you all the other descriptions, so I know which one you're talking about. There was
Yeah.
an elevation, B2, B3, and B4.
Yeah.
So B1 through B4 and ABR are in ST elevations on those leads indicate
LAD.
right corner, left, yes, correct, LAD blocked, right?
Right.
Inclusion, so we know there's a study.
Does
that make sense?
Okay, okay.
Does that make sense?
Yeah. That's what they kind of lost part in the,
So I have a couple of pressure waves, yeah, for, so when did we talk about pressure waves during this course? We did. Il ran it like, no, like, yeah. Pressure waves.
yeah.
Well, we have to be looking at them, well,
To identify
Huh?
gradients, yeah.
when we were confused and you did that,
Well, that was for Mr. Ochoa's class, but during this course, when did we talk about pressure waves and there's any, we did talk about, when we talk about pericardial diseases, remember, we talked about Bose paradoxus, we also talked about equalization of the pressures, right?
That's for cardiac.
Right, so.
what
You're gonna have a couple of things and you need to see what it is.
Okay, so
like
that,
based
Those
on
are
this
gonna get
pressure
you. I
wave,
need
is
to-
it cardiac
I just need the like it's never visible in PCL.
that or just like the thing which chamber we're
Yeah,
in.
to see, well, because we look at the numbers, right?
Right.
And
To
now,
remember the numbers and the pressures.
But even then, it plays with my head.
remember the cardiac situs solitis? Does anybody remember that?
The what?
Cardiac what?
It's cardiac situs solitis. It is on your book. I remember reading that.
Cardiac collided.
Yes,
Sinus light.
situs solitis.
Is that when your abdomen gets smaller?
No, that's a
That's
situs.
very-
That's a situs. A situs.
So that. How do you spell that? Will you spell?
Situs, situs,
Yes, thank you.
solitis.
What is that?
SOLADS.
What is it?
Solitis?
You tell me what it is. Look it up.
Oh, is that when the patient's feet is cold?
No,
The
it's just, what?
about the cardiac side.
What?
Be nice.
I'm reading aloud. Yeah, predominantly on the left side, right? What? Oh, shit, okay.
So in situs means place, right? Situs is in place. So in a situs solitis, your heart is on the left. Your liver and the gallbladder are on the right. The stomach and the spleen are on the left. So situs solitis means they're on the right place. Isn't the heart? Well, the heart is on the chest, leaning towards the left. Where is your liver? Which side of the body?
right?
Yeah, it's on the right.
Like, okay.
It's because they're thinking of looking at the picture, so.
Yeah, but look at your body. Like, where does it hurt? You know, when you eat a lot of grease, or like your gallbladder on your and your liver is on the right.
All right. Yeah.
It's on the right. Yes, and your pancreas is on the left. Yeah. So it's a condition where everything is in the right place because there's times in which
They're not.
organs are not. There's a switch.
Eso no me lo sabía en inglés.
It's not English. It's Latin.
Well, you know.
Sinusitis. Cirque du Soleil looks like. Cirque du Soleil. All right, and everything else we have talked about in the reviews.
Like the PowerPoint.
If they're sitting like this.
The reviews and the things. All right. We have to go, so I wish I can stay longer, but
Wait, I have a question. The cardiac sinusitis, do you know which chapter?
it might be on the congenital on the chapter. No. There's no class tomorrow. Tomorrow's exam is at 1. So you're gonna have 13, 14.